Hi guys, I'm MD2,
Welcome back to the podcast. I'm MD3.
and today we're here to talk about everyone's favorite calcium channel blocker, Verapamil.
Most people's favorite.
Well, anyone in EMS. You talk to any EM providers there.
Your only option.
So we recently got Verapamil kind of approved on the trucks. I'm going to talk to you a little bit about how it works. So it's called a calcium channel blocker. Calcium channels on cell membranes basically involve the influx of calcium, which helps induce calcium release, and things like the AV node in the heart. It actually, if you block those channels, it slows down conduction, which means that you're slowing down the heart rate effectively. But at the same time, calcium channels in the vasculature, the calcium is used to induce like muscle squeeze. So you're also blocking the calcium channels in the vasculature, so you decrease blood pressure a little bit because the smooth muscle around the blood vessels is also kind of inhibited. Now, Verapamil, along with its distant cousin diltiazem, are the two calcium channel blockers we use for heart rate stuff because it focuses primarily on the cells involved in like the heart and conduction and slowing down the heart rate, and has a little more minor effect on the vasculature, but there is still an effect.
And when you say heart rate stuff, we're mostly talking about AFib with RVR.
Yes, you might see patients on this for other things like a history of SVT or even just high heart rate, but that's the most commonly used one. Is somebody will say, "Oh, I'm on cardizem or I'm on Verapamil at home for AFib," and so we have the IV form here, and that's typically what our protocols are for using it for is AFib. Dr. Tom is going to talk to you about dosing here.
Yeah, so we use Verapamil over cardizem, which is typically what we use in the hospital. One, because it's readily stockable in the rig, so we don't have to worry about cooling it. It's a lot more economical to keep it around, especially if it's a medication that we're using, I'd say, less frequently than a lot of our other more frequent medications, your Zofrans, your fentanyls, those kind of things. And so that's why we think it's a good drug to be using in the rigs, and it is very useful. So the dosing is 0.1 mg per kg up to about 10 milligrams. And that has to be pushed over a couple minutes slow push. So if you're concerned about somebody AFib with RVR, so you have an irregular heartbeat, it's pretty fast, and I'm not talking, like low 100s, I'm talking 130s, 140s, 150s, somebody who's really piping along there, then getting an order post-radio to one of us or to Dr. Wagner for Verapamil is appropriate. A lot of times some nuances, though, for when I order it is if this is a new onset AFib with RVR and they're not on any sort of rate control medications, I may start with just 5 milligrams with a slow push, even if maybe their dose is really like an 8 or 9, and just to see how they do because they haven't really been exposed to any rate control medications. I'm also concerned if anybody's real hypotensive, because if it's truly just AFib with RVR and there's no concerns for like sepsis, septic shock, then that would be an indication for cardioversion. Or if their blood pressures are a little softer, then I really want to get fluids on board and then potentially giving the calcium channel blocker. But this is a medication that you want to be certain that you're not giving it in somebody who has a low blood pressure or a slightly elevated heart rate for other things that they're actually compensating for, right?
Right. So I think that's one of the things we get hung up on. We talk about when do we really use it. Now, you mentioned the high heart rate, and high heart rate can come from a lot of different things. When we talk about cardioverting or shocking someone out of AFib, we're doing that because medicines have failed and their heart rate is so fast that they don't have enough cardiac output. The heart's not filling, and it's kind of, the whole circulatory system is collapsing on itself. But there are times when a high heart rate is needed. So say that a patient comes in and they've got a high fever and they're super septic, right? And their blood pressure is low because they're in septic shock. Their heart rate's actually high because their blood pressure is low. So we see patients in sinus tach all the time from septic shock. But if that patient has a history of AFib, their sinus tach might actually be AFib RVR. And then that's where it gets tricky, right? Because now you have to tease out, is this patient's blood pressure low because their heart rate's 130 to 150, or is it because they got a temperature of 104 and they just need more fluid? And that's really the tricky part of giving rate control medications, in my opinion, because I wouldn't give, if somebody is septic with a heart rate of 150, sinus tachycardia, I wouldn't give them a beta blocker or calcium channel blocker or anything to slow it down. I would try and rehydrate them and get their fever down. And it can be real challenging. So it's one of those things to kind of keep in mind and keep for consideration. Now, the other thing is paying close attention to the blood pressure. I have a similar dosing practice to you. And because you can always add more, but when it comes to calcium channel blockers, it's really hard to take back their effects, you know?
Definitely.
Like, you can't add less. So, I mean, when it comes to the dosing, I typically I start really getting a little cautious around 100 systolic. And then if it's 90 or below, I'm really hesitant to
Yeah.
do more, especially if there looks like there might be something else going on.
Yeah.
So again, things like PE, sepsis, thyroid storm, all these other conditions that you may be worried about. And if you have any questions, like Dr. Thomas had said, we're available on the radio, and unfortunately, the fellowship being over, we won't be around as much, but we're always available to ask questions. And you should always go to the on-call. Dr. Wagner's always available for medical direction also, and he can help tease stuff out. This is an especially important medication, in my opinion, for the Tuscola cruise with 30 to 40 minute
longer
transfers.
transport times for sure.
One of the other things I think to keep in mind is that there's this kind of, it's not like a real scientific equation, but you hear it a lot. 220 minus your age is the maximum heart rate that somebody should really sit at, right? So, Craig here is a strapping 25-year-old lad.
Oh, so kind
His
of you.
maximum heart rate is like 195, 180 to 190, 185 to 195, right? So, if he's an AFib with RVR at 160 to 170 beats per minute and you're 15 minutes from the hospital, Craig's body can ride that out.
Yeah.
He'll handle it. I mean, but if you've got a patient who's 80 years old and their heart rate's 170, they're already past their limit, and
Troubles.
you need to be very, very cautious. For me, if I have a patient who's elderly like that, I'll often put on the pads to ward off bad juju. Not so much because they're needed, but just because I'm like, well,
Yeah.
want everything kind of covered.
Definitely. So I think, it's good that we covered verapamil and its dosing. And I would say, in short, if they have a fever, it probably isn't primary cardiac, and I'd be very wary about slowing that heart rate down, right? Fluid bolus challenge early on, also very good. And slow pushing. And then obviously, if somebody's getting low blood pressures, that you want to keep them potentially on pads so that you can move to a cardioversion if you absolutely need to. So
Agreed.
if anybody has any questions on any of that, reach out to us or Dr. Wagner. And thanks for everything you guys do.
Thanks, guys.